Hi, everyone. It's my pleasure to introduce the ASRM symposium entitled Adenomyosis and Infertility, Medical and Surgical Management Strategies. My name is Dr. Linnea Goodman, and I am a reproductive endocrinologist coming from Virginia Fertility and IVF, and I would like to introduce today's speakers. First, we have Dr. Paul Lim from Seattle Reproductive Medicine. He will be giving a brief overview of the pathophysiology of adenomyosis, and then we'll dive into the foray of its effects on fertility and medical treatment options. Next, Dr. Asada, a renowned professor from Japan, will be presenting a variety of severe cases of adenomyosis, including exploring their surgical management, reviewing the pregnancy rates after surgery, and possible complications after removal of uterine adenomyosis. In the words of Dr. Asada, adenomyosis is still a disease with many difficult problems. We hope that this symposium will be a step towards standardization of diagnosis and treatment. We hope you enjoy the symposium, and I now give the floor to Dr. Lin.
Ladies and gentlemen, first of all, I would like to express my sincere gratitude to the members of the committee and Chair Professor Goodman for inviting me to this adenomyosis symposium. Today, I would like to talk on surgical management of two severe cases of diffuse adenomyosis and pregnancy rate and complications after adenomyomectomy. As you know, severe cases of adenomyosis is not only a cause of infertility, but may also include severe dysmenorrhea, severe hypermenorrhea, and thus may also interfere with women's well-being. And management may include long-term usage hormonal or painkiller therapy, and may in the end require hysterectomy for adequate relief. This slide shows the history of surgical procedures for adenomyosis. The oldest procedure is the wedge resection of the uterine wall, reported in 1952. Since then, in the 2000s, various techniques of adenomyomectomy have been developed, mainly in Japan. As a complete adenomyomectomy, transverse H-incision method, asymmetric dissection method, and as a laparoscopic assisted adenomyomectomy, our triple flap method, mini laparotomy method. Furthermore, as a laparoscopic adenomyectomy, laparoscopic double flap method, and convex lens resection method. And recently, robot-assisted laparoscopy method have been tried. Let's introduce some typical adenomyomectomy. First procedure shows wedge resection of the uterine wall. The MRI image is a typical adenomyosis on the posterior wall of the uterus. And this MRI shows the posterior wall of the uterine wall. After wedge resection, you can see the uterine wall seen as a very thin layer. And this is the laparotomy finding after wedge resection. You can see the approximated site is depressed. If the pregnancy were to take place under this condition, uterine rupture might occur. This is a transverse H-incision method reported by Fujishita. This procedure is examined using electrocoagulation or laser knife surgery in comparison to older classic reduction surgery. asymmetric dissection method reported by Nishida in 2010. Adenomectomy is performed using round loop electrode and high frequency cutter. This surgery is performed more than 1,500 cases in one facility. However, this procedure is not intended for fertility sparing surgery. Triple flap method, we reported 2006. This is a procedure for severe cases of adenomyosis. This technique is based on new idea differ from conventional surgical method. This procedure has been reported to RBM Online in 2011. Also introduced on the cover of RBM Online. And in 2018, this technique was introduced to fertility sterility in the review of uterine adenomyosis and adenomyome surgical approach. Here, let's introduce a summary of 18 published papers, adenomectomy and its complications reported in the fertility sterility review in 2018. The number of uterine adenomectomy reported worldwide was about 2,400 cases at 18 facilities. Among them, the number of operations performed in Japan was 88% of the worldwide. Of these, the total number of pregnancies was 449 cases and 108 patients miscarried and 363 patients resulted in a live birth and 30 patients resulted with uterine rupture. In the result, clinical pregnancy rate was 18.9%, live birth rate was 15.3%, miscarriage rate was 24.1%, and uterine rupture rate was 3.6% for all deliveries. This slide shows list of 23 reported cases of uterine rupture after adenomectomy. Incision method of adenomyosis, contraceptive period, number of weeks of pregnancy for uterine rupture, its fetal number. One case was twin. Its method of surgical treatment. 5 cases are undergoing hysterectomy. Its bleeding volume. There were 4 cases bleeding volume of 3,000 millimeter or more. Fetal survival. There were 3 death cases and maternal survival. For factors causing uterine ruptures, the first possibility is wound healing disturbance due to excessive electrocoagulation. Regarding the 23 uterine rupture cases, after the removal of uterine adenomyosis, powered instrument has been used in 17 cases, 73%. Thus, it seems there is a definite association between uterine ruptures and use powered instruments. Second, contraception period prior to postoperative surgery. We will share this data later. This slide shows the frequency of the uterine rupture after surgery. As you know, VBAC after cesarean section or pregnancy after mammectomy are 10 to 100 times higher uterine rupture rate compared to other non-scarring uterus or scar uterus. In addition, VBAC laparoscopic mammectomy is more 5 times higher. Furthermore, the frequency of the uterine rupture after the mammectomy is much more higher than uterine mammectomy or VBAC cesarean section. Uterine rupture is very dangerous complication, not only for newborns but also for mothers, and it is a serious problem in perinatal management. Therefore, it is essential to provide patients and primary care physicians with information about the importance of operative informed consent and pregnancy management. Now, I would like to show you the actual procedure of adenomyomectomy by the triple flap method. Surgical cases are two severe cases of diffuse adenomyosis. First case is adenomyosis of the posterior uterine wall, and second case is adenomyosis of the anterior and posterior uterine wall. Main purpose for adenomyomectomy by the triple flap method are: first, all adenomyosis tissue is completely extracted using cold knife. Second, the reconstruction of the functional uterine cavity in favor of implantation. Thirdly, the reconstruction of the uterine wall strength to maintain normal pregnancy. The triple flap method is indicated for the following conditions. First, all the patient has adenomyosis involving more than 80% of the anterior or posterior wall of the uterus over 6 cm growth. Second, for causes of severe dysmenorrhea requiring administration of more than 5 days of painkiller or more than 1 day of bed rest per menstrual cycle. Thirdly, for cases of patients under 45 years age who desire to conceive or to preserve uterine function. Surgical management involves 3 steps. First step, laparoscopic procedure. First, observation of the pelvic organs and their configuration. Second, the adhesions are laparoscopically released. Second step, adenomyomectomy under minimum abdominal incision. First, complete extraction of the uterine adenomyosis. Second, reconstruction of the uterine cavity. Thirdly, construction of the uterine wall. Third step, laparoscopic procedure. First, hemostasis of inside surface. Second, application of hemostatic barrier for inhibition of adhesions. HSG is performed preoperatively to check the patency of the fallopian tubes and the size of the uterine cavity. Surgery should leave the fallopian tubes open so that natural pregnancy is possible as much as possible. This is a typical HSG of adenomyosis with the expanded uterine cavity and vascularization. Now I would like to show you the actual procedures. First case is adenomyomectomy of the posterior uterine wall. And Second case is adenomectomy of the anterior and posterior uterine wall. Main objectives of the triple flap procedure help to solve the following problems of the adenomectomy. Retaining tubal patency in order to assure fertilization. Preserving the uterine cavity environment in order to assure implantation. And reconstructing the uterine wall so that it can properly sustain a normal pregnancy. Here we introduce a posterior uterine wall adenomectomy using the triple flap method. First, after making a small transverse suprapubic incision, a rubber tourniquet for hemostasis is placed around the uterine cervix. Then the enlarged uterus is split into two with a scalpel by a median vertical incision extending into the uterine cavity. Once split, the uterine cavity must be washed out to prevent infection. Then the adenomyosis tissue is removed, leaving 1 centimeter of the serosal flap. And leaving 1 centimeter of the endometrial flaps. During these steps, it is essential to introduce an index finger into the uterine cavity to assure an adequate endometrial flap remaining. Then the tubal patency is confirmed. As needed, additional slice excision should be carried out for any remaining adenomyosis. Then the first endometrial flap suture is carefully closed using Swiss bicrete. Then we cover the endometrial first flap by overlapping the two serosal flaps. The surface of the second serosal flap is removed in preparation to overlap with the third serosal flap. Then we suture carefully to make no dead space using 2-0 bicrete. And the third serosal flap is sutured. After hemostasis, tacocomb is applied and the procedure is complete. This next case shows the same steps applied to anterior and posterior uterine wall adenomyosis. Again, the enlarged uterus is split into two with a scalpel by median vertical incision extending into the uterine cavity. Then adenomyosis tissue is removed and again leaving 1 centimeter of the serosal flap. And also, while inserting index finger into the uterine cavity, leaving 1 centimeter of the endometrial flaps. Adenomyosis has been completely excised with matching forceps to place the tissue under tension. After the adenomyosis is removed, the surgical fish is washed. Then the first endometrial flap suture is carefully closed using 3-0 bicrete. Then the second and third serosal flap are prepared to overlap, whereby surface of the serosal flap is removed and sutured. After hemostasis, biological material is applied and procedure is complete. After procedure, the condition of the uterine wall is observed using ultrasound. And we also observe the resumption of the blood flow using contrast MRI. This is the post-operative ultrasound image taken 2 weeks after the surgery. You can still see the coated particle of suture material, but no hematoma was found. This image was taken 3 months after surgery. The suture material has been dissolved completely and no complications were found. The reconstructed posterior wall of the uterus is formed to the same thickness as the intact posterior wall. Post-operative MRI showed that the majority of the affected tissue had been completely removed, and you can see the suture layer in the middle uterine wall. HSG performed 3 months post-surgery shows that the uterine cavity was maintained, as was patency in both fallopian tubes, and perfusion is normal. The patient becomes pregnant with a twin after 4 months post-surgery naturally, and cesarean section was performed because of the premature rupture at 34 weeks with the twin. This slide shows the conditions of the uterine wall observed during the cesarean section. You see the uterus with some remaining tachocomb but no adhesion, and the suture site is flat and no depression. This slide shows the recovery of the blood flow of the myometrial region after surgery. This case is the longest case in which it took 20 months for the avascular area to disappear. 2 months after surgery, a large avascular area is found in the uterine wall. 6 months after surgery, the avascular area is reduced. 12 months after surgery, the avascular area was further reduced but still remained. 20 months after surgery, the avascular area was almost gone. Of the 130 patients, 92 patients, 81% require 6 months to resolution the avascular area. 20 patients, 70% require 12 months to resolution the avascular area. 2 patients require 20 months to resolution of the avascular area. We have performed 113 cases of this procedure during last 20 years. This slide shows the clinical post-operative efficacy for dysmenorrhea and hypermenorrhea using the visual rating scale. Hyper and dysmenorrhea resulted in the dramatic reduction in both menstrual cramping and menstrual flow volume post-surgically. This slide shows outcome after surgical treated by the triple flop method. We have performed 113 cases of this procedure during the last 20 years. Of the 62 women, 54% who desire to conceive, 34 women of them subsequently conceived. Of them, 7 women conceived spontaneously, and 41 women, 85% conceived by IVFET. As a result, 14 women, 29% experienced the spontaneous abortion, and the remaining 34 women, 70% went to term, and all were delivered by elective cesarean section. Most importantly, there were no cases of uterine rupture during any of the pregnancies. This slide shows recurrence rate after adenomyomectomy during 20 years follow-up of 113 cases. In adenomyomectomy using triple method, the recurrence after adenomyosis requiring treatment was confirmed in 5 cases, 4.4% within 5 years, and 8 cases, 7.0% by 20 years, and 3 patients underwent hysterectomy 10 years, 13 years, and 9 years later due to recurrence after adenomyomectomy. In conclusion, this triple flap method for adenomyosis is a technique based on a completely new idea different from conventional surgical method. And this method of reconstructing the uterine wall by replenishing large defective uterine wall following wide adequate excision of adenomyosis tissue with normal uterine muscle. The flap method of reconstructing the uterine wall is effective not only adenomyomectomy but also large myomectomy and maybe the potential to contribute to the prevention of the uterine rupture by postoperative pregnancy. Thank you for your attention.